Hello, my name is Lisa Anderson, and I'm the Senior VP for the Center for Health Affairs, a Metropolitan Hospital Association located in Cleveland, Ohio, serving 36 hospital members across 9 counties. I'd like to welcome you here today to the first presentation of a 3-part series about the work and reporting Northeast Ohio hospitals are doing related to community benefit. Some of the key areas we'll cover today are to provide really a basic understanding of community benefit. We want to take a broad look at the activities, programs, and other ways hospitals report community benefit. And last, we want to learn a little bit more about the role hospitals play in covering gaps in healthcare costs for those individuals and families that are either uninsured or underinsured. I want to take a few moments at this point to take just a brief look back at how community benefit reporting came about and how that ties into some other requirements hospitals must meet in order to maintain their not-for-profit status. So the backstory on community benefit is that it was a topic just about 50 years ago, back in 1969, beginning with an IRS ruling that hospitals should start to document contributions they made in the communities they served in lieu of paying federal taxes. At that time, the IRS did not make this a mandatory regulation, but over the years, that really rapidly changed. In the early 2000s, there was mounting pressure by states and eventually federal legislators who began to question whether not-for-profit hospitals should continue to be exempt from federal taxes based on the amount of community benefit and the type that they provided. Consequently, in 2007, the IRS issued a regulation requiring nonprofit hospitals to report community benefit as part of their annual 990 form. And you might recall that 990 forms are required of all nonprofit organizations, whether they're hospitals or not. However, the hospitals were required to provide an additional form called Schedule H. Reporting started in 2008 and was fully operationalized in 2009. Just for the record, the for-profit and government hospitals, as well as some other types of healthcare facilities, are not required to report community benefit. However, we do see that some of these organizations develop a community benefit type report that goes out on an annual basis to the community, and that's really in order to demonstrate the commitment and impact that they have in their health programming for the communities they serve. In 2010, the Affordable Care Act was passed and went even further to require community health activities and reporting, in that hospitals complete an annual, community health needs assessment, also known as a CHNA, and that had to be completed every 3 years. In addition, hospitals were also required to complete a 3-year implementation plan that accompanied that CHNA, and that was based on those key health priorities hospitals identified and how they were going to address those health needs in the communities they serve. So as you can see, all of these requirements, the Schedule H, the CHNA, the Community Health Needs Assessment Implementation Plan, have all had a direct effect on the importance of community benefit to hospitals. And it's in order so that they maintain that not-for-profit status, but also that they're really recognized for the community benefit work. So specifically, just taking a look at community benefit for hospitals, the objectives are to improve access to healthcare services, enhance the health of the community, advance medical or healthcare knowledge, and also relieve or reduce the burden of government or other community efforts. And we're going to get into more detail about what those objectives mean and how those are translated into that community benefit report. At this point, I'd like to introduce my colleague, Bob Kaliszewski, who has spent over 50 years working in the field of hospital finance and reimbursement. Bob works with our hospital members in Northeast Ohio on issues of reimbursement and regulatory requirements, such as Medicare and Medicaid, along with analyzing and creating the annual Northeast Ohio Hospital Community Benefit Report, which you will find on our website. So I'd like to welcome Bob to our presentation today.
Thank you, Lisa, and hello, everyone, and glad you could join us today.
So we're going to start off with some questions for Bob around community benefit. And Bob, just at a very basic level, to what extent have the Center for Health Affairs hospitals provided community benefit?
Well, the hospitals have just finished the filing of their 2019 community benefit reports, and the 2019 community benefit reported by our member hospitals for the services they render in the 9-county area is $1.8 billion. Now, this is up 12% from last year's figure of $1.6 billion, which was up 6% from the previous year's $1.5 billion. So as you can see, the community benefits is a growing service from our hospitals.
So over the years, the hospitals have really contributed to increasing that amount of community benefit through their programming and their services. I've mentioned that community benefit is made up of a number of components. Bob, can you give us really a broad overview of what they are?
Well, the IRS identifies 3 major components of community benefit: the financial assistance and means-tested government programs. The second is the community benefit services, and finally, the community building activities.
So are those categories broken down even further?
Yes, they are. Let me first touch briefly on the community benefit service and community building activities before I address the financial assistance and the mean-tested government programs in more detail. Community benefit service in general are programs that respond to identified community health needs. Programs and activities directed to the underinsured and the uninsured, and programs offered to the community to improve the community health. In 2019, community benefits were reported at $662 million, and it's broken down into 5 basic categories. The first is community health improvement service and community benefit operations, and that totaled $41 million. These services do not generate patient care bills. They include community health education, community-based clinic service and screening for the uninsured and the underinsured, support groups, enrollment assistance in public programs, self-help programs, and community health initiatives addressing specific healthcare needs. The second type of community benefit is health professional education. And in 2019, this totaled $428 million. And what this is the cost of providing education training for physicians, interns and residents, medical students, nurses, nursing students, and other health professionals when the education is necessary for a degree, a certification, or training is required by law for licensing. This health professional education is the largest contributor to the community health benefit services. The third category is subsidized health service, and that totaled $41 million in 2019. This encompasses clinical programs that are provided despite financial losses. So significant that the program reflects a loss even after we remove the negative effect of bad debts, financial assistance, charity care, Medicaid shortfall. The programs continue because it meets a community need, and this service would be unavailable to the people in the community if the hospital were to drop the program. Research includes clinical and community research that is shared with the public, as opposed to research that is considered proprietary or developed strictly for internal purposes of the institution. And in 2019, this benefit totaled $136 million. And the final type of community benefit service identified by IRS is cash in kind contributions for community benefits, which was $15 million. Cash in kind represents cash and in-kind services donated to community organizations. In-kind services include contributed staff time while they're on the clock at your organization, the cost of meeting space, and donations of food, supplies, equipment, etc.
So if we took a really broad look at what you just described to us, we can think of programs that folks are familiar with in the community, such as, immunization clinics, screenings, health education talks, and then even, training that and educating that future workforce. So when you see student nurses or residents in the hospitals, that all is going towards that community benefit, those community benefit categories. And then, of course, research is, terribly important in our Northeast Ohio region for our hospitals to be able to continue to do that and, gain recognition for that work that they're doing to advance health research and, seeking solutions for some of the most troubling issues people face in their healthcare situations. So let's move to community building activities. Bob, can you give us, this is a totally different category, so can you give us some idea of what that represents?
Yes, community building activities address the root cause of community health problems, such as poverty, homelessness, and environmental hazards. And the IRS identifies there are 9 types of community building activities. There's physical improvement and housing, which includes neighborhood improvement and revitalization projects. The second is economic development, which includes participation in economic development councils and councils such as the Chamber of Commerce. Community support includes efforts to establish community support services such as neighborhood watches and child health care for community residents in need. Environmental improvement includes training community members to monitor and reduce environmental hazards and neighborhoods and community efforts to decrease litter. Leadership development and training may include the cost of conflict resolution training, community leadership development, cultural skills training, and life or civic skills training. Coalition building is the cost associated with a hospital representation to community coalitions that address economic revitalization and affordable housing. Community health improvement advocacy is related to local, state, and national advocacy on behalf of transportation and crime and includes advocacy for social justice and human rights. And then there's workforce development, which addresses community-wide workforce issues, and it may include recruitment of underrepresented minorities, job creation and training programs, and in-school programs on healthcare careers. The final category, identified as other, represents cost of community benefits operations in the hospitals, staff managing and overseeing the community benefits program, costs related to the organization's community health assessment, cost of developing a community health plan, overhead and office expense associated with the community benefit operations, and finally, the software supporting the community benefits program. And in 2019, these community building activities totaled $1 million, and of that 1 million, 84% of it was represented by 4 of the activities. Community support at $422,000, community health improvement advocacy at $275,000, leadership development and training at $107,000, and coalition building at $50,000.
So if we take a look, again, as some practical examples of those community building activities, they're really outwardly facing. When you think of the partnerships that the local school systems have with area hospitals, when you think of, doing things like expanding internet access in, specific neighborhoods, those are all examples of those community building activities. So those are a lot of categories so far. And I know one of the areas we wanted to cover today was really reporting that's done around community benefit activities related to financial assistance and reimbursement shortfalls. So can you give us some information about those 2 categories?
Well, there are 2 distinct programs known as financial assistance and the mean-tested government programs. These 2 programs are the largest contributor to the community benefits overall. In 2019, these programs reported $1.3 billion of community benefit, 878 million of it in mean-tested government programs, and 254 million in financial assistance.
And can you tell us what the differences between financial assistance and means-tested programs are?
Financial assistance is provided to individuals who are directly responsible out of pocket for all or a portion of their bill. The individuals must meet the hospital's eligibility requirements for free or discounted health services. Means-tested government programs refer to federal, state, county, and local government public assistance healthcare programs generally available to individuals with limited resources. Let me first address the unpaid portion of a bill that is the patient's direct responsibility. The portion of a bill that is the patient's responsibility includes services not covered by their insurance policy, the deductibles or co-insurance required by their insurance policy, or the total bill for those who are uninsured. Unpaid patient bills are reported on a hospital's financial records as either bad debt or free care. Bad debt refers to unpaid portions of patient bills in a case where the patient has the ability to pay but does not pay. The IRS does not consider bad debt a community benefit. Free care, on the other hand, is a community benefit in the eyes of the IRS. Free care is further distinguished between charity and financial assistance. Charity refers to individuals living below the federal poverty level and have no insurance or resources to pay for services. These patients are deemed indigent and are not required to pay for services rendered. Financial assistance refers to patients above the federal poverty level who are uninsured or underinsured and may be eligible to have a portion of their bill forgiven.
So when we take a look at those last two categories, both charity care and financial assistance, this is really going, those programs are really supporting the care of those most in need, people who either can't pay because of their income, they have no other resources or ability to pay for services, yet they receive services. And then we also have individuals who may have a portion of their bill forgiven. So for example, I know we've talked in the past of individuals who may have, some form of health insurance, but they're called what we call the working, poor, and they can't afford their co-insurance or they can't afford their co-payments. And so they, could possibly be covered under that financial assistance program. Are there any other additional requirements that hospitals provide or are required to provide for those individuals that are under or uninsured patients or their families?
The Emergency Medical and Treatment Act, EMTALA, passed by Congress in 1986, prohibits by law the denial of care in emergency situations to indigent or uninsured patients based just on their lack of ability to pay. Because of EMTALA, hospitals must meet additional requirements in order to be deemed as tax exempt. Added to the IRS code was a provision requiring hospitals to have a formal written financial assistance policy and an emergency medical care policy. The financial assistance policy, referred to as an FAP or a FAP, applies to all emergencies and other medically necessary care provided by the hospital. And this policy must be made available in writing to the patients, and the hospitals are required to have signage in key areas like the ER or in the business office to inform the patient of the availability of the service. Now, let's turn to the shortfall and mean-tested care programs. Shortfall and mean-tested care programs is recognized as a community benefit. The shortfall is the difference between the cost of providing service to patients covered by means-tested public government programs and the payment received from these programs. Medicaid is a joint federal and state mean-tested government program. Means-tested is another term for income and assets of an individual or a family. The eligibility for the program is based on these resources or income. Eligibility for Medicare benefits is available for individuals and families living at or near the poverty level. There are more than 3 million recipients of Ohio Medicaid in the state. And in our 9-county area, there are over 788,000 Medicaid recipients in the areas served by the Center for Health Affairs. Each year, the U.S. Census Bureau puts out a poverty threshold used to measure the number of individuals and families who are facing poverty. For 2021, these thresholds are single-member households, $12,700. For a two-member family, about $17,200. For families of two with one child, it's $21,700. And if for every additional child after that, it's $4,000 to $4,500 that is added to that level. Now, Ohio has a expanded Medicaid program, raising the federal poverty limits an additional 38% for eligibility.
So I'm going to stop you there for a second, Bob, and talk a little bit about EMTALA. So in other words, anybody coming into the emergency department of a hospital has to be evaluated and treated. So they can be admitted or they can be discharged home with instructions on how to care for their medical condition. But they're not going to be denied care because they don't have financial resources to pay. And then second, with our federal poverty levels, which change from year to year, we're also seeing that with expanded Medicaid that went into effect some years ago within the state of Ohio, that we've seen an increase in the enrollment numbers, more people being eligible. And I would dare say even with over the last year in 2020, we've seen even more people eligible for Medicaid as incomes have really fallen through loss of job and changes in their individual and family economic situations. So at this point, we're going to have you talk a little bit about Medicare and Medicaid, which are our two largest public payers.
Pay hospitals less than the actual cost of services rendered. Medicare and Medicaid underpayments occur because these two large public payers set reimbursement rates through rule and regulation, rather than negotiating rates such as the private payers or managed care organizations. Typically, the Medicare and Medicaid payment laws set the hospital payment rates below the actual cost of providing care to program beneficiaries. These underpayments of cost are referred to as shortfalls. Now, data from the most recent American Hospital Association annual survey of hospitals revealed that Medicare and Medicaid shortfalls nationwide totaled $76.8 billion. The most recent HA data showed that hospitals only receive approximately, on an average, 87 cents for every dollar that they spend caring for Medicare and Medicaid beneficiaries. About 2/3 of hospitals nationwide receive Medicare reimbursement at less than cost, while 62% of the facilities are being underpaid by Medicaid. The center's review of the 29 community benefit information reported by our member hospitals reveals that the Medicare and Medicaid shortfalls are 111 million and 878 million respectively.
So you can see really those levels in Medicaid, and the amount of funds that are reported vastly outweighs what that reimbursement is with, or that shortfall is with the Medicare program. And so if we didn't have Medicaid, there in a way to be able to care for those patients through the hospital system, it would be a really devastating situation for people in our community in getting their healthcare needs met. So in other words, people are not denied care, and they potentially can fit into one program or another to be able to continue to receive care. So do those Medicare and Medicaid and Medicare shortfalls qualify as community benefit equally, or is that something that is treated differently by the IRS?
This is a yes or no answer. The yes is Medicaid is defined as a community benefit because it is to qualify for Medicaid coverage. The individual must meet eligibility requirements related to their income and assets, which is their means. And the no part is that Medicare does not qualify as a community benefit because it is not means tested. Individuals qualify for the Medicare program based on their age, 65 and over, and certain medical conditions such as chronic kidney failure. There are no resource limit qualifications for Medicare. Patients are eligible for Medicare based on age and not by their financial position. And although Medicare shortfall is not a community benefit in the eyes of IRS, the low payment rates set by the program result in underpayments of the cost of the services rendered to the patients, and thus a financial loss to the hospital.
So I think one of the things that runs through people's minds is, just the cost of healthcare. So it's obviously a very complicated situation, and multiple programs, play a factor in how the hospitals get reimbursed for the care that they provide. Similar to Medicare shortfall, are there other services that hospitals provide to benefit the community that are not reported as community benefit?
Well, yes, there is. Hospitals are major employers paying. Yes, hospitals are major employers paying out wages and benefits to the members of the community, who in turn are paying taxes on their earnings to local, state, and the federal government. Compensation and benefits paid by our member hospitals in 2019 totaled $8.6 billion compared to $8.1 billion in 2018. In addition, our member hospitals provided 497,000. In addition, our member hospitals provided 497 million of services that went unpaid as bad debt in 2019.
So at the beginning, and just to step back for just a second, so hospitals are some of our largest employers in the community, and those costs associated with having employees are not attributed to their community benefit, yet they really benefit the economic vitality of any region. When you have people employed, they're spending money and they're, living here and that kind of thing. So it helps to strengthen, our local economy through that employment situation. And then also, some of the other services that hospitals provide are, really help to, strengthen our community. And as Bob said, those unpaid debts really can mount up over the years, and we've seen that shift over the last couple of years. At the beginning of when we started talking, we're making a comment around the IRS reported 990 reported community benefit for 2019 was 1.8 billion. So what would the revised community benefit be if we were able to add in that Medicare shortfall and that bad debt?
The 2019 figure would increase to $2.4 billion if we added in those categories.
So summing it up, when you take a look at pure community benefit, as we've talked about today, our local hospitals year over year are providing well over $1 billion and really approaching $2 billion to the Northeast Ohio region through their community benefit efforts. And as we move into 2021, the community benefit report for 2020, the year past, so when we get towards the end of the year, the hospitals will be filing their community benefit report for 2020. Do you think we're going to see a shift in those numbers due to the pandemic? Are they going to go up? Are they going to stay the same? If you could look into that crystal ball, Bob, what would you predict?
Well, I expect to see increases in the 2020 community benefits that are being reported for a couple of reasons. The first is the hospitals in Northeast Ohio have been focusing on the COVID-19 response. They never shut off their community benefit programs. In fact, the pandemic has increased the need for these vital community programs that help connect patients with the resources needed to address our region's public health challenges. The community benefit programs offered by the Northeast Ohio hospitals seek to help patients address issues such as providing legal aid to addressing housing conditions, navigate care for better access to physical health as well as mental health, and many more services that try and reach the root cause of health disparities. As much as 80% of a person's well-being depends on factors outside of the hospital's direct care. So all the different programs offered by our hospital members attempt to address these social needs as much as possible. Secondly, the economic impact of the pandemic has led to an increased unemployment and economic downturn in which there's an uphill battle to return to the pre-pandemic economy. These unfortunate circumstances have resulted in more patients not being able to pay for services as a result of losing health insurance coverage due to job loss. As noted earlier, the payments from the two major government payers, Medicare and Medicaid, are not covering the cost of rendering service. And this economic climate will lead to an increased amount of bad debt and charity care that all hospitals will have to provide. And the third and final reason for the possible increase in 2020 benefits spending is the fact that Northeast Ohio hospitals represent a hub known worldwide for research and education. Our area hospitals are currently producing research on how to best treat the COVID-19 patients, long-term impact of COVID-19, and working on COVID-19 vaccine research. So as you can see, in spite of these economic issues, our member hospitals stand ready to meet the community's healthcare needs.
And as we can see, that's even, going to be increased with the amount of commitment and services and outright delivery of healthcare in the community during the pandemic. So I think we'll be interested to see what those numbers show when we get closer to the end of the year, beginning of 2022. So we'd like to wrap up for today, and I'd like to thank Bob for the insights that you've provided to us, and that really well of resources and information you have for all of the years you've been working in the area of hospital finance and reimbursement. I think we've all learned a great deal about community benefit and how really hospitals are instrumental toward improving the health of the communities, both on their own footprint, on their own campuses, but also in those outward-facing activities that go on across the Northeast Ohio region. And it really goes towards improving the health of the communities, but also preserving access. That's critically important, that we have access for individuals and families to healthcare services and healthcare treatment. Want to put a little teaser out there. You may have gotten a note about this, but this is a series. So we're going to be hosting a second talk on February 2nd with our president and CEO, Brian Lane, for the Center for Health Affairs, who will be hosting a panel discussion. And we will be hosting representatives in community benefit from Ashtabula County Medical Center, Mercy Health Lorraine, the Metro Health System, and St. Vincent Charity Medical System, along with their partner, the Legal Aid Society of Cleveland. And they're going to share in some unique and interesting ways of how they provide community benefit to the communities that they serve, as well as within their hospital footprint. And that will be around community building and community health improvement programming. And then our third and final talk will be held in March, on March 12th, and Patricia Tursteniak, who's our Director of Community Health at the Center for Health Affairs, works every single day with community health needs assessment work, implementation plans, and really, is part of that community benefit work that hospitals are delivering out to the communities, very knowledgeable. She's going to be discussing the work of some of our other Northeast Ohio hospitals to support health education, professional education, and research. And we're going to be hosting speakers from the Cleveland Clinic, Southwest Medical Center, and University Hospitals. So please join us for those two upcoming talks. Please reach out to us if you have any questions, and we'd like to thank you for